Alright, let's talk about a condition we encounter fairly often in the field, but one that can deteriorate very quickly if we don't act early. It's acute cardiogenic pulmonary edema. When we arrive at the scene, it's usually obvious that breathing is the main problem. The patient is sitting upright, breathing rapidly, and can't get more than a few words at a time. Sometimes you can hear a wet crackles from across the room. In these cases, we need to do three things: recognize the condition, understand what's happening inside the body, and follow a clear, structured plan. So what's actually going inside the body? In cardiogenic pulmonary edema, the problem almost always starts with the left ventricle failure. The left ventricle simply can't keep up with the blood returning from the lungs. Pressure begins to back up into the pulmonary veins and capillaries. As that pressure rises, fluid is pushed out of the capillaries and into the lung tissue. Eventually, it reaches the alveoli, where it interferes with the normal gas exchange. Meanwhile, the right side of the heart and the rest of the body continue to do their job, to send more and more blood to the lungs. That ongoing flow only adds to the congestion, which is why this condition can develop so rapidly. One of the first things I want to know is the patient blood pressure. It gives me important information about how well the body is compensating and where we are along the spectrum of this condition. Blood pressure isn't just a number on the monitor, it helps guide how aggressive we can be with our treatment. If the blood pressure is high or within the normal range, it usually means the body is still compensating. The vessels are constricting in an effort to maintain perfusion and keep blood pressure up, even as the lungs begin to flood. If the blood pressure is low, that's a very different situation. Now we are talking about cardiogenic shock, and our priorities have to change. Sometimes the blood pressure appears normal, but it can be misleading. On paper, the patient may look stable, while organ perfusion is already beginning to suffer. So blood pressure is not just a number. It's a clue that helps us guide our next steps. Clinically, these patients often present with a sudden shortness of breath. They are unable to lie flat and will insist on sitting upright. Breathing is rapid, often well over 30 breaths per minute, and they may appear anxious or restless. On long auscultation, you will hear crackles, usually starting at the bases and progressing upward as the condition worsens. In more advanced cases, the patient may produce pink, frothy sputum. And here's an important point to remember. If the oxygen saturation does not improve significantly with a simple oxygen mask, that's another clue we are dealing with the fluid in the lungs, not just an airway or ventilation problem. It's important to understand that pulmonary edema is not always caused by excess fluid in the body. In more than half of these patients, total body fluid is actually normal. The problem is not how much fluid there is, it's where that fluid is. That's why, in many cases, the goal is not just to remove fluid from the body. It's to redistribute it by reducing the preload and the afterload. So let's get to business. Step 1 is simple: positioning and oxygen. Sit the patient upright. That alone reduces venous return to the heart and immediately makes breathing easier. Then, start high-flow oxygen using a non-rebreather mask. It's fast, simple, and buys time. Before anything else, we need to make a critical decision. Can this patient be managed with non-invasive ventilation? Or are they failing and heading towards intubation? If the patient is awake, cooperative, and able to protect their airway, CPAP is often the best next step in acute cardiogenic pulmonary edema. CPAP works in several important ways. By increasing the intrathoracic pressure, it reduces the preload. That means that less blood returns to the heart. It also reduces afterload and makes it easier for the left ventricle to eject blood forward. And finally, CPAP helps to recruit the alveoli. That improves the oxygenation and pushes fluid back into the capillaries. But there is an important caveat. If the patient is hypotensive, CPAP can actually make things worse by reducing preload too much and dropping cardiac output even further. If the blood pressure is adequate, with a systolic pressure of 100 or above, nitroglycerin is my first-line medication. I usually start with a single sublingual dose of 0.4 milligrams and then move directly into CPAP. From there, the next steps depend on the patient's response and the resources that are available to us. If symptoms improve and blood pressure remains stable, we can continue CPAP and reassess. If additional vasodilatation is needed, we can give up to 3 sublingual doses over several minutes, or we can transition to the intravenous nitroglycerin and titrate the doses needed. Nitroglycerin works by dilating blood vessels. Venodilation reduces preload, so less blood returns to the left ventricle. Arterial dilation reduces afterload, making it easier for the heart to pump blood forward. The end result is lower pulmonary capillary pressure and improved forward flow, exactly what we need in acute cardiogenic pulmonary edema. At this point, a lot of people think about diuretics, and that's understandable. Furosemide or Lasix is a powerful loop diuretic, but in acute cardiogenic pulmonary edema, it's usually not our first move. That's because it relies on the kidneys receiving enough blood flow to be effective. In the early stages of acute decompensation, renal perfusion is often already compromised. So even if we give it early, it may not have much of immediate effect. Once we have improved forward flow and stabilized perfusion with CPAP in nitrates, diuretics can become more effective. At that point, intravenous furosemide can help by reducing intravascular volume and supporting further decongestion, with dosing adjusted to the patient's condition. Now, if the systolic blood pressure drops below 100, the entire strategy changes. In these patients, unloading the lungs is no longer the priority. Maintaining perfusion and supporting cardiac output comes first. In hypotensive patients, nitrates are contraindicated. CPAP should also be avoided, as reducing preload further can worsen cardiac output. Diuretics should be used with caution, as they're unlikely to help in the first few minutes. In these situations, supporting perfusion becomes the priority. Inotropic support, such as dopamine, may be needed to improve contractility and maintain the blood pressure, while the underlying cause is addressed. When additional vasodilation is needed, we can transition to intravenous nitroglycerin. A practical field approach is to give 1 to 2 milligrams intravenously every 5 to 10 minutes, carefully titrating to symptom relief, while closely monitoring the blood pressure. The medication is typically diluted to 50%, with a maximum total dose of around 12 milligrams per hour. Once forward flow and perfusion have improved, intravenous furosemide can be considered. Typical dosing is approximately 1 milligram per kilogram, up to a maximum of about 120 milligrams, or 2 times the daily dosage of the patient. And it's worth remembering, in many of these patients, we are not trying to aggressively remove fluid, but to redistribute it away from the lungs. If the blood pressure is low, this represents a different clinical pathway. In these patients, maintaining perfusion takes priority over unloading the lungs. Dopamine can be started at 5 micrograms per kilogram per minute and titrated as needed to support cardiac output and blood pressure. Doses above 10 micrograms per kilogram per minute add more vasoconstriction and should be used cautiously. Ultimately, it's important to remember that pulmonary edema is a symptom, not an underlying problem. Always look for the trigger: acute myocardial infarction, arrhythmias, hypertensive crisis, or acute valve failures. Obtain a 12-lead ECG early and communicate key findings to the receiving facility as soon as possible. Managing acute cardiogenic pulmonary edema is about recognizing it early, understanding what's happening physiologically, and acting decisively in the right sequence. Thanks for listening.